Good evening, friends. This evening we have selected two topics, short topics to be discussed. Both are very important. First, we shall discuss injury prevention in elderly patients. This is in continuation to our series on geriatric surgery and prevention of trauma in geriatric population is important from two aspects. Number one, the magnitude of even smaller trauma in elderly population carries more mortality and morbidity. Number two, the healthcare burden in terms of finance is huge impact on any country if we want to deliver good quality of healthcare. Number three, lot of it is preventable, manageable, or the incidence can be decreased. Now, coming to some statistical figures, the elderly population will increase by 50% in next 20 years. Currently, and trauma constitutes the top 10, it comes in top 10 causes of mortality in elderly age group, and there are a lot many unintentional injuries. We don't have Indian data, but as per American data, around 50,000 people are injured. They die out of trauma in geriatric age group. 3.9 million people are treated for trauma every year in the United States. Female are more prone to injuries. Males are more prone to traumatic brain injuries. The direct medical cost to United States of geriatric trauma is $34 billion. Plus, $34 billion is the cost paid to the hospital either via Medicare or by the patient, plus loss of earning for the patients and their caregivers, which in other words, relatives and attendants. Now let's look at what are the risk factors for an elderly person to have trauma. There are two types of situations. One is called non-modifiable factors. The non-modifiable factors are the age, gender, and cognitive decline. In age and gender, as we said, the female are more prone to trauma. And age beyond 65 is more prone to trauma. The cognitive decline means as there is longevity, as the age increases, the dementia, Alzheimer and non-Alzheimer type, depression, and cerebrovascular accidents, microvascular disease, they all increase loss of memory and added on it virility. Welcome, Dr. Shakti. And virility is added on. And then there are modifiable factors. The modifiable are impaired visual and hearing deficiencies and the environmental factors. For say environmental factor means the bad roads, the stepping up without warning to the patient, and extremes of temperature. These are few things which can be modified. Though we are discussing this today, let me take back to you to around 40 years ago when I was a resident. While I was preparing for this lecture, I got more motivated and respectful to my mentor, Dr. Forrest Carey Eggleston. You know, the pattern in CMC was somebody who's met with an accident. The resident was supposed to present on the round, why did the accident happen? Now, there could be three common causes of accident in Punjab, the motor vehicle accident. One, the guy is alcoholic or drug addict. He was intoxicated, so he had an accident. Then, as soon as his splenic injury is recovering, there is a psychiatrist and a psychotherapist visiting to educate him and to de-addict him. Number two, the gentleman did not have right kind of vision. He never knew. So many drivers we found out who needed glasses and never knew them. We found out several colorblind people. So every patient before a suture removal will be routed through eye department. Very interesting. I would say still 40 years down the lane, it is still rare in India that a surgeon digs into this area to find out why did the accident. We are all becoming more tubularized. We all think about, I have done a best anastomosis, I've done the best liver resection, I did a vascular repair, excellent, and the patient has pulsatile flow. But very few of us bother to get into the detail, and that is why I said today's lecture is an eye-opener for young and not so young people also, because it is those not so young people who are going to educate our next generation. Accident happen, because solving this liver tear, this bowel tear is 50% of the job. The 50% is that fellow not to have that accident again 2 years later. And at times we will find that the patient has got, the driver got some vital part of the truck welded repeatedly. So some kind of education is needed on that also, that the cost of life is much more than replacing the part. So I'm trying to say, digging into the history, looking into the environmental and modifiable factors. Well, in elderly population, some of the other factors which predispose to trauma are hypertension, diabetes mellitus, cardiac arrhythmias, and so on. There are some drugs which predispose to trauma. The drugs used for dementia, depression, and anxiolytics. Oral hypoglycemics, NSAIDs, and anticoagulants are also associated with increased incidence of fall. Now, in United States, there is a orange book published by American Society for Trauma, which tells all the details of resource of optimal care of injured patient. This gives in very meticulous detail about every single protocol of prevention of trauma. I have gone through it. It is free, available on net. All those youngsters who have some inclination to trauma, they can read it, but mind it, this is not needed for your exam purposes, and there is no limit to the knowledge which one can get. So let me divide the elderly trauma or geriatric trauma into subtypes. Number one is the fall. When we say fall, that means somebody falls on the ground while standing. So this is the leading cause of traumatic brain injury and hip fractures. 1/3 of people who have dependent living, while in Western world there is assisted or dependent living for those, because nobody's child has got time. In Indian system, somebody who is bedridden, who needs help, who needs walker to walk, who needs some assistant for his daily jobs would be called as assisted living. And this 1/3 becomes 40% beyond the age of 80 years. The female are more likely to fall, but their falls are non-fatal. While statistically, the white females are more likely to die out of falls than their African American origin people. There is people who are discharged from hospital following any illness are more prone to fall and have hip fractures. Now, hip fracture has emerged as an important entity which is called isolated hip fracture, IHF. We will consider this in another lecture because isolated hip fracture is much graver injury than we ever thought. It carries very high mortality and very high morbidity, not because of fracture alone. It is because it happens in an age group which has so many comorbidities on it. But as an overview, if we have 100 people who fall, only 20 require medical attention. 80 falls, they fall at home, they get up and go back to their work. But it is important for a clinician to record for somebody at a higher age, geriatric age, when he comes to hospital to ask the history, sir, did you ever fall? The guy may say, I fell twice last year. I mean, this is the guy who's likely to fall in the hospital too. And, 5% of falls will have associated fractures. Now, hip fracture is the most feared situation. Can you believe in some series, 25% patients with hip fracture will die. 75% will have lesser mobility and 25% would be always on assisted living. Hip fractures in patients above 80 years of age. 50% of them will never walk again and would suffer from pressure sores, pneumonias, and dehydrations and recurrent urinary infections. Traumatic brain injury on an average has 80,000 visits to hospitals in a year. And 40% of them are just spontaneous falls. So if we come to traumatic brain injuries, mortality, it is related to one important factor. Those geriatric age group who fell on the floor, if they have one comorbid condition, the mortality is 20%. If it is 2, it is 30%. If it is 3, it is 60%. If it is 4, it is 80%. Now, addressing their risk factors. When we say risk factor, means if we are taking care of their modifiable risk factors, the mortality decreases by 50%, which is a substantial point. Now, how can we control this elderly fall? Now, I've told you the magnitude of injury, the suffering for the human being, the financial loss which either the government pays or the patient pays. It is as preventable, manageable as tetanus. The only thing is we are not aware. Now, let me share with you a story why this lecture is designed today. I was highly motivated. Last week, I was with a classmate of mine who is a neurologist in Austin, spending a day with him. And he said, Giri, it's time to go to gym. Would you like to go with me? I said, sure. And both of us were there. And then in one hall, I saw all elderly people gathered together. And then out of my curiosity, because they were all in a group, everybody elderly, then I asked to my friend that, what is this going on? Then he said, well, this is an elderly accident or injury prevention exercise group. It's amazing. And then I need to dig into it. And then when I read more and more about it, then I thought, in my free time while holidaying here in chilly Cleveland, I must share with you what is happening across the globe, how people are putting their effort to prevent such accidents in elderly age group. People are motivated themselves. There are organizations which are helping. So now there is a consolidated program called Stopping Elderly Accident Deaths and Injuries. Now, what is in that? They are trying to correct the correctable factors. All the medical risk factors, physiotherapy, exercise, and adjusting their medication dose. People should not be dopey, over given drugs for Alzheimer. All these levodopas, they produce sedation, and the drugs to give them adequate vitamin D to keep their bones in good shape, and checking orthostatic hypotension. See, all these are modifiable factors. Now, when I read more and more about it, there are programs in every country. Well, our country cannot have a program because the leadership, the political will is nil. But all through this platform, along with Dr. Patta, Radhakrishnan, my friend, we'd like to put an appeal to all the surgeons on this platform that within our community where we stay, to our neighbors, to our patient population, we can educate. You see, America has a program called Step On program, where there are 2-hour session over 7 weeks to educate muscle training, balancing, and foot prevent fall. New Zealand has a program called OTGO, which has 1-to-1 physical training. The physical therapist trains every person about 65. How do you prevent fall spontaneously? There is a similar program in China. There is a similar program called MOB, the prevention of fall in elderly people in Boston, where they meet for 8 weeks, 2-hourly session to educate people how to prevent falls. And there were exercises like standing on one leg, keeping the one leg up, all exercises meant to strengthen the calf and the thigh muscles and the hip movements. And they were told how to walk, what kind of footwear, not to walk on a slippery surface, and things like that, so that they do not fall. The idea is not to treat more and more head injuries. I know prevention of injuries does not give us any money, but this is our social and moral and professional responsibility for primary prevention of trauma. The second cause of trauma in geriatric age group, besides fall, is motor vehicle collision. For mobility, the elderly have to drive themselves because nobody has the time. Now, beyond 65 years of age, there is 34% increase in accidents, and accidents are related as the age goes beyond 65. As the number of miles covered per month go up, the incidence of motor vehicular collision go up. Now, because the elderly people, what are the differences? It is analyzed. What are the differences between an elderly driver and a young driver? See, elderly drivers fall. This is a statistical data by American Trauma Association. They follow the rule. They don't take the risk. They wear the seat belt much more than the national average. Strange. In this process of lecture, I am also learning a lot of new things which I'm trying to share. The American data, Trauma Society data, is only 66% people wear seat belts in younger age group. When they compared it with elderly population, around 85 plus percentage were wearing the seat belt. They were not drinking and driving. They were not driving at night. So all the five things leading to decrease number of motor vehicular accidents. But when it happens, their severity is more. And because of age, osteoporosis, and virility, with lesser impact, I hope you understand, in any road accident, the energy transferred is mass multiplied by a square of velocity divided by 2. That is the impact of energy on the human body. So elderly people have more diagnostic investigations. They have more inpatients, hence their cost and problems go up. Now, as far as motor vehicle collision is concerned, I had already told you Dr. Eggleston's vision even 40 years ago, what he did. And now what is currently supposed to be done, that all the futuristic vehicles would have an automatic braking system like we have right now in Volvo. It's very good that even a cat crosses the road, the Volvo would slow down and stop. And if the vehicle in front puts a brake, your Volvo will automatically brake for you. Then there is a consolidated driver rehab program in US. If somebody is elderly, he has some difficulty in driving, he goes to the company and the agent who sold him the car, there is somebody who would educate the driver to set his mirrors, to set the position of his seat, and if needed would help to put if the guy has short legs or long legs, to adjust the pedals to his height. This is called a driver rehab education program. And we have an excellent contribution by Dr. Virender Bansal, the current chief of AIMS on this. Well, the study was done in US while he must be a fellow here. I read his article, Virender Bansal, and there are several American authors. They have found that the 4-point fixation seat belt and a broader shoulder belt had lesser injuries compared to the regular seat belt. Now, after the elderly trauma, motor vehicular accident, we would like to discuss elderly abuse. Well, elderly abuse can be of two types. The physical abuse, which is the act of physical pain or injury to a person. And welcome, Professor Maheshwari. And neglect. The neglect is abandonment or failures of a designated caregiver to deliver that care. It could be unintentional or intentional. Well, the abuse is variable and is something like a chronic disease. Now, somebody who has abused today may be well for quite a bit of time till he develops it again. So, a detailed history. The suspicion of elderly abuse, the onus lies on physician. The primary physician or the primary trauma surgeon needs to look at a patient that if he has an elderly abuse, that can only be picked up if we are sensitive, if we are looking to a total human body, a person, a gentleman, and not looking only at a urethral rupture or a fracture femur or a rib fracture. We should be looking more in totality. Only then we can pick up elderly abuse. The point is we should listen separately to the patient in privacy and to the caregiver separately. Only then we will, because in front of his son who's neglecting his father, no father would dare to complain against the caregiver. And in United States, a suspicion of elderly abuse is enough for a doctor to report. A doctor doesn't have onus to prove that whether the abuse has actually occurred or not. There are agencies who would look into it. Educating the doctors is primarily an issue to pick up and prevent elderly abuse at the next time. Now, the last specific issue for elderly population is suicide. Believe me, this is an eye-opening for me. 12% of total suicides, well, again, it's a Western data. We don't have Indian data. 12% of total suicides belong to people who are over 65. And 18% of total suicidal death also are over 65 years of age. This is the third common cause of injury in geriatric population. Commonest weapon is a firearm. There is a term called silent suicide. One may say, I'm talking psychiatry, but we are the people who deal with trauma-related suicides. And I will tell you an interesting story of my youth having dealt a couple of suicides. And the silent suicide which is not reported, is drug overdose, self-starvation, dehydration, depression leading not eating anything, anorexia, and the patient conks off, and it looks that he has died a natural death. Now, what are the risk factors for suicide in elderly population? The white males and people in chronic pain and depression and social isolation are the causes. One very interesting fact, that 70% of patients who committed suicide met their primary care physician in last 1 month before they committed suicide, thereby meaning that the primary care physician was not sensitive to look at which elderly patient is likely to have suicide. Now, there are some indicators to share with you which patient is likely to have suicide. Somebody who loses his interest in activity, who stops doing his social activity and not coming to his doctor regularly, then somebody who used to come to you always well shaped, well dressed, when he comes ungroomed to you, he has loss of a person, a spouse or a young child, and who has insecurity, financial or social. There are two things we must give very much seriousness when we communicate with our patients. One dialogue is, "Doctor, this is the last time we are meeting and I am seeing you." Second, "Doctor, I'm not going to require any further appointments with you." These two dialogues are statistically found to be significant in a patient population which commits suicide. Now, the prevention is only one way. We need to have social awareness to the caregiver, to the primary care, that this is the group of people who can commit suicide. Keep the firearm and sedatives away from such old people. And the psychological therapy along with antidepressants can help to prevent suicide. Let me tell you an interesting story. Around 35 years ago, I had in Haryana, uh, one of the common modality of committing suicide was hanging. So a girl miscalculated her body weight and her chunni and hung herself from the fan, and she was brought to me hypoxic, and she had tracheal disruption. Whatever surgical needed to be done, ventilated, she got well. When she got well, like back because of my background training, I tried to dig in. Why did she commit suicide? And when I talked to the patient, a young girl was willing to die only on a small issue, that she wanted to have a boy cut, which 35 years ago was considered to be a modernity sign. And the conventional Haryanvi family did not allow uh, anybody to, a girl to have a boy cut in Haryana. So the mother-in-law was against boycott and the girl wanted boycott. Now this is such a small issue. The girl was willing to die. So eventually I got both parties across the table and negotiated. And eventually we allowed the girl to have a shoulder cut. And she lived happily thereafter. And some 25 years later, I happened to do a hysterectomy on her. So what I'm trying to say, each one of us, surgeons on an average, have more social impact than any other specialty. I can tell you, I have people who were, you know, uneducated people who, when I saw a scar on their belly, I asked, where were you operated? He said, in Lahore. I said, who did it? Then he said, Sir Williams. Now this uneducated guy remembers the name of his surgeon 30 years later or 40 years later. So surgeons have more impact, and we must encash this aspect to the benefit of society who has given us this importance. So that finishes prevention of trauma. To summarize, elderly people are prone to trauma. We have features, we have factors which we cannot modify. There are factors which we can modify to some extent, to extremely. Some factors like adjusting the drugs, some factors like giving a proper hearing aid, looking after their vision, and looking after their vision. These are the features which can be taken care of. Educating them on their fall by exercise and balancing exercises, taking care of their footwear, and educating them how to avoid fall. Similarly, on motor vehicles, similarly identify people who are at abuse, and also identifying people who are likely to be suicide prone and prevention of them. So this finishes first half of the lecture. Now there is a smaller topic with lot of impact on the management. We'll take 10 more minutes. This is chest wall injuries in geriatric age group. Now, thoracic injuries lead to 25% of fatality in injured people. 10 to 25% patients with rib fractures are there in all polytraumas. In all polytraumas taken together, the sternal fractures are less than 1%. Whenever they're there, that is thought to be more serious issue. In geriatric age group, more than 50% of isolated rib fractures were due to only fall from standing area. The motor vehicle accidents, the seat belt system was more responsible for rib fractures. The incidence increases after 65 years of age. Now, when we consider associated comorbid conditions, congestive cardiac failure is considered to be the worst prognostic area. Pneumonia secondary to rib fracture increases the mortality 4 times. I repeat, rib fractures associated with pneumonia, mortality 4 times up. Increased ICU stay, increased time of ventilation. Now, if it is so that we have isolated that with rib fractures, pneumonias increase the mortality. So what should be our target? Number 1, to prevent chest wall injuries, and number 2, if they have happened, to prevent pneumonia. If pneumonia has happened, to anticipate and pick it up early and treat it aggressively. Now, seat belt, I have told you, Dr. Bansal's philosophy, 4-point fixation, wider belt. They also suggested one important thing, that the companies, when they check they put up dummies for the injury detection. So they should put dummies matching the fragility index of elderly population, and where the bones break much earlier. Now, whom to admit with rib fractures? Anybody who is 65, 3 or more than 3 ribs should be admitted. Second criteria, anybody who has more than 65, more than 6 rib fracture, even there is no associated injury, they should be admitted in ICU. Now, increased risk is associated with pneumonia and intubation. Now, what are the risk factors? Number 1, COPD. Number 2, CHF, congestive heart failure. Number 3, poor nutrition. Number 4, people who have a chest tube. It is not only the chest tube, it means the patient also had either pneumo or hemothorax by the virtue of associated lung injury. Those who are in assisted living, that means their muscle mass, their all issues are already low down, and when the rib fracture is more than 5. So when the injury severity score, now for postgraduates, you are all supposed to know ISS, because it can be a short note, it can be discussed in practical exam. Now, the newer concept. Now, the second thing is, once you have admitted, now we have only 3 points to discuss on a rib fracture. Number 1, pain management. Number 2, prevention of pneumonia. Number 3, fixation if any needed. So, getting one by one, let's first discuss the pain management. Now, there's a very decent bedside protocol which is through Wellspan York Hospital from Pennsylvania. Now, these people have classified and created a score. The youngsters who are interested, please note down. If you look into net PIC score, P stands for pain, I for inspiration, and C for cough. This is all bedside scoring. I repeat, P for pain, I for inspiration, C for cough. The scoring is, if the pain is very severe, it is 1. If it is moderate, it's 2. And if it is Controlled, it is 3. Inspiration, if the patient cannot perform incentive spirometry, it is 1. If it is lower than the expected tidal volume, it is 2. If it matches with the tidal volume, it is 3. It is above the tidal volume, it is 4. Similarly, when the patient coughs on bedside, somebody who cannot cough because of pain, it is 1. If somebody can weakly cough, it is 2. If somebody can really cough like a Punjabi, then it is 3. So put together, pain has got 3 points, so does the cough, whereas inspiration has got 4 points. So the total score is 10. Lesser the score, higher the chances of lung complication, higher the chances of pneumonia, intubation, ventilation, higher the mortality. So this is an objective parameter. All the 3 tests done without any cost and predict the prognosis. You also can judge between Monday and Tuesday, is my patient going up or downhill? So PIC score should be popularized in India also. If it is done here, why can't we do it there? So let's come to the pain management. Pain management is under 3 headings: oral, IV, and regional. So let's talk oral. Oral are usually for isolated hip fractures who are not admitted. Number 1. Number 2, when you are weaning off, stepping down from IV analgesia, then you can use oral. There are 2 things interesting in oral medication is that NSAIDs and opioids put together help in better pain control. But whenever you are giving NSAIDs, please consider the bleeding risk and the renal failure or associated renal failure. Now, use of when the pain is lesser and can be managed with oral drugs, the combination of aspirin with gabapentin has been useful to control pain. The IV analgesics are useful, but there is a risk factor of over sedating. Let me share a protocol. It is, again, the protocol is more than 40 years old, as practiced in CMC surgery department. It was what is now called as patient controlled analgesia. But patient controlled analgesia can happen in a conscious alert patient, not in intubated patients. Now the formula is dilute. For example, if we are giving morphine, or let's say pethidine we are giving as analgesic in severe pain, 100 milligram of pethidine is dissolved in 10 cc of saline, and the resident sits next to the patient. He gives 10 milligrams IV and waits for 3 minutes while he keeps talking to the patient. Another 3 minutes, give another 10 milligram. Another 3 minutes, another 10 milligram. So we want to titrate a level where patient says he's pain-free, but he's still not drowsy. Once we have titrated that this particular gentleman gets pain-free with say 35 milligrams of pethidine. So then we write on the chart that titrated dose is 35 milligram. So next time when he has pain after 4 hours, he gives stat again, only 35 milligram stat. So that is one of the ways which I have lived with and has been good throughout my life and useful. Currently there are better modules available and which can add on. Now today there are multimodal analgesia, and that would be a separate issue to discuss. This aspirin gabapentin is part of multimodal analgesia. I can while I will be back home in next 2-3 days, I can organize a good lecture on multi-modal analgesia. Our chief of anesthesia, Dr. Neeta, is very good in this, and maybe I can request her. It's not my specialty to answer this, and but you have a valid question. And now, control by regional block, there are 3 routes which we have. Number 1, epidural. Epidural by far is very good when we can give either epidural analgesics or opiates as continuous infusion pump, and this is useful. An advantage is you can have on bilateral effect by epidural analgesia. Number 2, there are some difficult situations where we cannot practice epidural. Number 1, patients, and this is quite often in polytrauma. Number 1, patients who have associated spinal fracture. Number 2, who have coagulopathy. People who have massive liver trauma also have associated rib fractures. And this is the community where because of coagulopathy you cannot give epidural. There is an epidural problem associated where patients are likely to develop hypotension. Now another modality is that a catheter is put in paravertebral area and you can have continuous infiltration through the pump of local analgesics to control pain. The advantages is there is no hypotension when you have continuous paravertebral catheter, number 1. Number 2, it does not, but the side effect is you cannot use it in bilateral fractures. This is good only for unilateral fractures. Now, respiratory therapy is another very important factor in the management. First important thing is pain control. Second is prevention of complications. Respiratory therapy has statistically been proven that every 10% increase in vital capacity in first 48 hours decreases the pulmonary complications by 1/3. So if the vital capacity is increased 30%, there should be no pulmonary complications. Now, last point in rib trauma is operative fixation. Interesting. In a survey, only 26% of general surgeons in America have ever dealt fixation of rib fractures. There's a term like a slang they use, on the way fixation. On the way fixation is they were doing thoracotomy for massive trauma of bleeding because of azygous vein was injured. So on the way, since they were doing a thoracotomy, they fixed a couple of ribs related to that. Now, what are the definitive indications of elective rib fixation in today's era? They are far and few, but the postgraduates should know that when, because of a massive anterior flail, bilateral sternal flail, the patient is not able to wean off. Number 2, when the pain is persistent because of unstable fragment. And number 3, when there is a chest wall defect you are going to repair anyway, or associated with gross deformity of the chest wall, or non-union of multiple ribs. So these are few indications of open fixation. Patients who have associated pulmonary contusions, and they are less likely to benefit from open fixation. There are no separate studies of open fixation in rib fractures in geriatric age group. Hence, they cannot be committed upon. So that comes to end of rib fractures and chest wall injuries in elderly people. Thank you very much, everybody, for being with me late at night. And it is very interesting to share with you a sub-zero temperature. Here, all ice around, 2 feet snow with snowstorm in Cleveland, and I'm just across a glass wall sitting comfortably. It has been a wonderful session with you guys. Thank you very much for your comments and for being with us. Let us propagate on LGS. Whatever we share here, we're trying to bring back whatever is the learning here should be transferred back home, and all of us can contribute to prevention. Through this today's session, the prevention of elderly trauma is one issue, and the second important issue is to classify our chest wall injuries, and through classification of pain, inspiration and cough, we can objectively predict is our patient going up or down, and involve our paramedics to bring the patients and our respiratory therapist to bring his score from lower to the upper one, so that we have less pneumonias. Less pneumonia means lesser mortality. Thank you very much.